So over to you, Ike. The field is yours.
Well, thank you, Arup, again. Thank you, and thank you to the all my Indian colleagues in AIOS and all the folks that are doing this great work. You guys always do things really big, and of course, this is my kind of my homeland, so it's always a little closer to my heart. And thanks, Arup, for all the education that you do at all the meetings and virtually as well. So these are my presentation slides here. I will talk about capsulorhexis tricks. These are my disclosures. And so really my presentation can be long or short. This is really a very simple presentation. I can basically just present this video, which is femtolaser capsulotomy, and then my presentation is over. So Arup, we have 20 more minutes. You have to open the floor for discussion. But really, there's much more to capsulotomy than femtorexis. And of course, you know, femto technology is still being discussed and debated. You know, I have done many femto capsulotomies. We are still debating the value of femto versus non-femto, and I won't get into that. But I think the mastery of basics and advanced capsulorhexis techniques is critical for any phaco surgeon. And I will try to go through some basics and some advanced tricks when it comes to doing capsulotomies and capsulorhexis in routine and advanced cases. And I really think that this is, part of the procedure that I think, you know, we always talk to the residents and fellows about being at one with the eye. You feel like you're at one with the eye. And I think when you do the capsulorhexis, you get a real feel for how the case is going to go. And it gives us a qualitative assessment as far as the capsule, as far as the zonules. And I think it's very valuable. We also know that for many of you, it can be difficult. It can cause autonomic dysfunction when you think about a capsulorhexis, or even when you're having to deal with a tough one. So I hope these pros will help you. Let's remember the capsule anatomy. This type 4 collagen, which is one of the thickest basement membrane in the body, which is again typically about 14 to 20 microns in the anterior extent of it, is what we are talking about here. Remember that the mechanical properties of the capsule changes as we get older. We lose the elasticity as we get older, which can be plus and minus. Of course, in young patients who are very elastic capsules, it can be very challenging, of course, for the capsule to want to run out. Also, remember, as we get older, there's more convexity of the anterior lens. This changes the vector forces of the capsulorhexis. We need to consider this, of course, when we do our capsulorhexis, because we use vector forces. It's important, of course, to always remember a few principles and pros that I've listed here. We pressurize the eye. We always remember to use the incision as a fulcrum. We want to be deliberate in our motions and understanding the physics of what we do here. We all know, I think, the value of doing a good capsulotomy and a capsulorhexis, I think, is quite evident in terms of the importance for safety, ELP, positioning of the lens, reduction of PCO. And as was mentioned earlier, if the lens has to be removed, it is a little easier if there's anterior capsule overlap to lift off the capsule off the lens. What we want to see is a nice capsulotomy present with good overlap, and you see the edge of the IOL beyond the capsular edge. So remember, viscoelastics are really important. They pressurize the eye. They help to counteract the tendency to run out. But also we need to be mindful that we don't want to overinflate the eye either. So it's always a steady balance. I think the one weapon that we all use in our surgeries that's most important for me is the capsulorhexis forceps. And although many do needle capsulorhexis, I think the control with a forceps, particularly in complicated cases, I think is optimal. So nothing wrong with learning needle and doing needle capsulorhexis, but I prefer a capsulorhexis forceps. And the cross-section forceps, I think, have some value in terms of, you can see the difference in these. These can go through a 2mm incision, and they have the advantage of this in working through smaller spaces and less gaping of the incision. You see the difference with the regular standard capsulorhexis forceps, and I think you see the obvious differences here. So cross-action are helpful, and this is typically what we do. Of course, a microforceps is also very handy as well for folks to use as well. Remember the difference between shearing and stretching. We typically use shearing approaches where the force is at the plane of the capsule and it's directed parallel. And we take advantage, of course, with the smoothness of this tear, and it's very controlled. However, it doesn't allow for any abrupt changes in direction. And this is where stretching basically can help to direct the forces perpendicular to the direction of where we want to tear. When we do this stretching technique, some people call it ripping, other things, I think these are the good terms to use. we can really adjust the positioning of the capsular rexis. These figures from Barry Seibel very nicely show the importance of vectors. That you see the vector forces and the torquing of the shearing movements of the hands, depending on the capsular flap. For those that are learning, it's good to unfold the capsular flap completely, keep it unfolded, and then tear close to the surface of the anterior capsule for better control. When the capsular rexis is bunched up, like on the bottom right, it's less controlled. And remember, if the capsular rexis is running out, we need to change the direction of our vector. You see, for example, in red, we will grab the flap and tear more centrally, which will cause a tear to come in more. So always remember, vector forces are important. This is kind of a standard capsular rexis. I have a moderately sharp tip capsular rexis forceps. We make an incision in the center, and then we grab one edge of the capsule, and then we tear toward a direction. In this case, it's going to be clockwise. And again, notice how we're using a shearing technique. I don't totally unfold the flap because I've gotten comfort in doing this, but it is helpful to unfold if you're not sure. And regrasp, again, you see about maybe 1 millimeter to 2 millimeters from the apex of the tear. Continue the rexis. And if you look at the rexis, when we tear the rexis with shearing, you can actually see that the forceps itself is basically outlining the direction of where we're going. And so actually, in a usual case, you can see how the rexis is being propagated, and the forceps are actually following the same contour of where the rexis is going to tear. And this is a good way to kind of approximate the vector required. You can see the forceps are actually tracing the outline of where that tear will go. Frequent regrasping is helpful. I'll just show another case, and I want you to look in this case. I want you to look particularly at the incision here, and just look how the forceps are being used with the incision being as a fulcrum, avoiding the turning. Very, very commonly with beginners, a lot of tension is placed on the incision, and the eye is moving around, and the viscoelastic is escaping, and the tear is not as controlled. So you can see how the forceps are torqued in the incision, are rotated in the incision as a fulcrum, and again, you can see how the tear is being followed along to outline the rexis direction. You can see the forceps are basically leading the tear in a shearing fashion. And those are some good approaches. We do have digital markerless systems, which also are nice and handy. You can see here we've marked the cornea as well in this case. So there are many different imprints you can leave on the cornea with marking tools that can be helpful to guide the tear. And also in this case, you can see we're also using a digital overlay system here. And this also can provide some guidance in terms of sizing as well, which is another nice tool. Is a necessity? No, not a necessity, but it's just something that some find it useful to have a bit of a guide and its image overlay in doing it this manner. Well, the rexis runout, of course, is something we all have to be mindful of. And there are certain eyes at risk. Small eyes, of course, is one of the risk factors as well. We want to make sure we pressurize the eye very well in these cases. We need to change the vector force, and we need to be comfortable to convert to a stretching tear. In some cases, we have to actually restart the rexis and reconnect it if it really runs out. The again, principles here are converting from a shearing to a stretching technique. And Brian Little has published a nice paper many years ago. And this video will just show the tear started here. And as the tear is propagated to the nasal side, you'll see that the tear is starting to run out. You can see it's okay here, but the surgeon is losing a bit of control here. It's running out a bit farther. It's still salvageable. And this is where the surgeon should have changed the vector. But you can see how the tear is running out closer to the iris here. Well, what do we do here? Well, again, Brian Little has published some nice articles. These are some of our examples here. The same case here, the tear is going. The green arrow is the direction of your vector of the forceps. And look what's happened. It's run out. Now, one can stop and put more viscoelastic in. If you put more viscoelastic in, don't put it centrally. Put it peripherally. If you put the viscoelastic centrally, it can cause a tear to run out. This is an important pro for beginners. Put it in the periphery here. And then, and in fact, you can even avoid this if you actually convert to a stretch right away. Unfold the flap completely. Grab the flap about 1.5 millimeters from the apex of the tear. And then pull the flap 90 degrees to the direction you wish it to change. So if you want the direction to change this way, you will pull the flap in a 90-degree direction. So it doesn't mean to the center. It means 90 degrees to the direction we want it to tear. Now the tear has been redirected. We can then again back and fold the capsular rexis back and continue along with the capsular rexis as we should. Here's just to show the video again. The capsular rexis is tearing out, You can see it's running out to the pupil edge. Unfold the flap, even before viscoelastic, you can do it right on the fly. Grab about 1.5 millimeters from the apex, and then pull 90 degrees to the direction we want to go. We want it to go this direction. We're going to pull in this 90 degrees direction, and you can see a little bit of tension there. Sometimes you have to pull, sometimes you have to really give it a jerk, and you continue along with the capsular rexis. It's just a simple way to save it, and we should all be comfortable with the stretching approaches. So another example of a more Intumescent lens, you can see the capsular rexis is starting off okay. Probably would have been useful to maybe start a bit smaller. And as we get to the subincisional area, you'll see the rexis is starting to run out. It's running out here, running out here. Oh, it's really running out here. We need to stop. We need to basically unfold the capsule and then pull 90 degrees away. And now we can see we redirect it. I'll just show you again. It just happens very quickly here. And rather than stopping, injecting viscoelastic, we're just going to convert to a stretch, grab, pull 90 degrees to the direction of the flap you want to tear it. And there you have it back in position there. So keep in mind this approach here. This is a surgeon starting capsular rexis. You can see it's starting off slow. The rexis is continuing along here. And as we get off to the, about 3/4 of completion, the rexis is running out. You can see how it's run out here. I'm pointing to the arrow here. It's really run out under the anterior capsule. The surgeon is trying to redirect it. But really you need to grab, see my cannula is pointing to where we should grab about 2 millimeters or 1.5 millimeters from the apex, pull to the center very quickly, and redirect it. And there you have the rexis has been redirected there nicely as it was running out there. So again, another approach there as well. This example here, the rexis is running out and is too far run out. So we're just showing the rexis is started. It's run out really far in the periphery there. Really, you cannot see it anymore. And it was felt that we could not redirect it. In this case, what one can do there, it is it's way out past the pupil margin. It's running out probably to the equator here. In these cases here, we can restart the rexis from the initiation site and making a little cut in the capsule where the rexis was initiated, again with a 27 gauge needle in this case, we create a little flap. This flap is then grasped, and then the capsular rexis is rejoined to where it ran out. It's helpful to let it run out a little bit as it's going toward the area of run out to allow it to sort of meet to the apex of where it ran out. But sometimes we have to resort to these situations here to allow the capsular rexis to continue, or one can convert to a can opener, of course, as well. So to cut and then reconnect is another option as well. This is an example here where the surgeon started the capsular rexis, and the rexis is running out here. You can see subincisionally, it's really, really far in the periphery here. And so the surgeon, we had to stop and then cut. You see, look how far it's run out, really far out into the periphery here. So sometimes making another incision and using a pair of micro scissors can be used to amputate the flap. And here we're basically cutting with the scissors and amputating the flap where it's run out. And so you have a discontinuous capsular rexis. You see where it's run out there. And the problem when we do this is that if we allow the chamber to shallow, in some cases, as you'll see here, look what happens in this case. Everything's intact so far, but watch very closely. And there the rexis is wrapped around into the posterior capsule. So there's a risk when we cut the capsular rexis where it's weak and it can run out, where we see this happening. And so whenever we see a discontinuous rexis, there are important principles to remember. It's another example here where the capsular rexis has been initiated. You can see it's running out toward the periphery here. And the surgeon is unable to save it. You see it's run out way in the periphery here, right there. And even using the little maneuver to try to stretch the capsule isn't enough. So we'll have to cut it and amputate it. In these cases here, it's important that we have certain principles that we have when we manage these cases. The most important thing for me is to make sure the chamber doesn't shallow. The chamber shallows, then the capsular rexis may want to run out. And of course, we avoid traction in the area where it's running out, and all these important principles are there and present important. Small pupil rexis, well, I think it's pretty straightforward. You know what? Use a Malligan ring. It really is a nice way to get pupils enlarged. The other option, of course, is to use iris hooks to help to expose and reveal the capsule. In this case, you can see it's a small bag. And in these cases here, we have to make a small capsular rexis. Otherwise, of course, we lose the anterior capsular shelf. But you can see the benefit of having really good exposure with iris hooks that can be really helpful here. We do also look at doing small pupil rexis without using any pupillary guides. And I call this, kind of under the covers. What I mean by that is basically we're doing the capsular rexis under the iris. This is a bit of a higher order skill. What we're really looking at is observing the behavior of the flap. And as we tear the flap, as you see here, if the flap is moving nicely without any stria, then we can be assured the rexis is basically continuing in a proper fashion. And that gives us a bit of assurance. Now, the use of a Kuglen hook can be useful as well, but it does give us, an advantage of not having to manipulate the iris excessively. Again, it's no problem to use iris hooks and Malligan rings, but I think if you're comfortable doing it without it, it's nice to not have to be reliant on this. And here, actually, we have good visibility. We can see the tear occurring, and we can actually follow the tear as it tears. We know that the capsular rexis will be well positioned as we get more comfortable and we get more experience. And I think that doing it without any aids is something that can be helpful and useful. When we have an intumescent lens, of course, we know the risk of capsular runout is higher because of the pressurization of the capsular bag. Trypan blue is put in, and what's very important here is to use a good super viscous agent. We typically use Helon 5 to really pressurize the eye to flatten the capsule. One pro that many have talked about, which is nice, is using a 25 gauge needle to aspirate the lens material upon the initial puncture of the anterior capsule. This will decompress the capsular bag, and blotting the nucleus back also allows for fluid to come around. And then we can continue along with our rexis here. So doing the initiation of the capsular rexis along with aspiration, I think, is a nice way to allow us to do this rexis without it running out, which of course is the risk. These still may run out, so it's good to make it a bit on the smaller side if you're not sure. And we can see that the rexis is nicely formed. Well, what about capsular folds like this case here? You can see on the OCT, we can see significant capsular folds and thickening of the capsule in this trauma case. And we see with vision blue, we see these capsular folds. It is very difficult, like you see here, to get a good capsulotomy. We tried to decenter it, but I had to cut it with a scissor. And I think that's something that we have to always be aware of. These trauma cases can be very difficult. Again, Trypan blue is helpful. We'll put some triamcinolone to evaluate the vitreous and do vitrectomy. But doing the capsular rexis, you can see, very difficult. We try to incorporate the capsular plaque within the capsular rexis, but this is a large capsular plaque with lots of folds present. And these folds basically make it difficult then to do a continuous rexis. This also has loose zonules as well. And here, I think the best answer is maybe femto might be helpful here, mind you. But if you don't have femto, then using an RF or a Clody device may be helpful, or using micro scissors like this to basically start the initial capsular rexis and then do as much of a tear as you can, and then use sharp instrumentation, whether they're needles or whether they're forceps or scissors to propagate this tear. And you see there's certain areas where I can do a continuous tear. It's nice to do a continuous tear in some areas because it may allow the lens to be better positioned, even though the capsulotomy will be irregular. And so the use of micro scissors are helpful. At the end, we will use another cut here along the temporal side to allow us to make this one continuous rexis. So it's just something to consider when we manage these cases that are challenging. The pediatric cataract is also one to be mindful of. We typically have to make adjustments, including the use of a super viscous agent like Helon 5. Again, very helpful, like you see here. But also just watch as we do the capsular rexis, how the capsule wants to run out. And so we need to change our vector forces to really pull toward the center. And you can see by doing this, we're exaggerating the vector that we're pulling with, but it allows the rexis to be performed in a good, proper manner to allow us to continue and create a nice round capsular rexis. And that's something I think that is a helpful approach in these challenging cases. The other thing I think is nice to do as well in these situations here, when they're pediatric cataracts, is to be comfortable doing a posterior capsular rexis. And here you can see we're going to inject viscoelastic and then use a 25 gauge needle to break the capsule and then continue with the capsular rexis. Now, this capsular rexis is like an anterior capsular rexis. The difference is it's thinner and we're working at a more steeper angle. And so it's helpful to use a microforcep. It's helpful to viscoelastic behind the posterior capsule to maintain Berger space and keep vitreous back, keep the anterior hyoid intact. And then we basically need to regrab. The big difference between posterior and anterior rexis is the need to regrasp frequently because it's very thin and not as controllable. So regrab frequently. But really, if you can do an anterior capsular rexis, I believe is something that you can reasonably do quite well a posterior capsular rexis. And again, this may be something that is helpful in pediatric cases like here, or maybe also helpful when we have, for example, a PC rent, as you see here. The PC has been opened during Phaco with a circular cut with the Phaco tip. This may be stable, but really it's at risk for running out. So make a little snip and then basically convert this to a posterior rexis. And so posterior rexis is a nice way, again, to manage a tear, to create that nice continuous curvilinear tear, which will allow us to create a nice capsular bag and put the IOL in the capsular bag. Let me just show you maybe just two more cases of a zonule case here. One thing to keep in mind in these cases is the capsular rexis is not going to be the same size and the same shape as a regular capsulotomy. Make these ovalized, in this case, follow the contour of the bag and make them smaller than you normally would. Otherwise, we run into the zonules here. Remember, the capsulotomy will stretch. Once you put a capsular tension ring in or segments in, the capsulotomy stretch. Look how round it is now after you put the CTR and CTS in. And even with the CTR and CTS in, you can see we're also doing a posterior rexis in this case. Again, start the rexis with a sharp needle, bevel down, inject viscoelastic, and then do your capsular rexis. And be sure to try to get it centered here and make it at least not more than 5 millimeters, maybe a little bit less even. So if you wanted to, you can also do a posterior optic buttonhole. And by that, I mean basically put the lens in the eye, as you'll see, and prolapse the optic behind the capsulotomy. So those are just some tricks and pearls, Arup. I just want to, again, thank you for having me here. Lots of stuff to talk about with capsular rexis. I have more videos, of course, online, and always love to see you all on social media, which has been our only way to keep in touch, unfortunately, during the pandemic. And I look forward to seeing us all in person, and whether in India or otherwise in the future. So thank you very much, Arup, for inviting me here.
Thank you so much, Ike. Wonderful series of videos.